That was terrific, Lynn. And I think you threw out some concepts and proposals at the end there that we will definitely circle back on during the discussion. Let me turn first to Ben, though. Ben, it would be great for you to take us down to ground level and share with us your experience at the VA, what this actually looked like to a clinical leader, and how that experience informs your wish list for financing and payment.
Sure, I'm happy to. And I did have some slides, if someone can put the slides up. Great, thank you. And I'm going to apologize in advance. My puppy chooses the exact time that I'm presenting on a Zoom call to become really badly behaved. And the more people on the call, the worse their behavior. So you will almost certainly hear something in the background. I've been just really floored by the discussion so far, and keep wanting to say, oh man, you guys have to hear about what we're doing in the VA, because so many of the ideas that have been floated, obviously we have an opportunity in the VA as an integrated kind of payment and care delivery system to really try out a lot of stuff. Not that we're not hitting, lots and lots of potholes and barriers, but I'm gonna just talk briefly about that, and then in 30 seconds about my experience in the private sector trying to do similar things previously, which is easy to summarize quickly. But actually, I was asked before I launch into telling you about our specific initiative to just give you a quick primer on VA. A lot of people don't know much about it, so I'll do that really quickly. Next slide. Well, there's a nice slide. And just to make a point, we are working, and so are some folks in Congress, to change that wonderful motto from Abraham Lincoln to care for they who have borne the battle and their widows and orphans, etc. So we're going to get there soon. Next slide. So the Department of Veterans Affairs, which is a cabinet level department since 1989, second largest department after DOD, and within VA, there are 3 different administrations. VHA, which is the health system, VBA, which pays for benefits like the GI Bill, and the National Cemetery Administration. Next slide. So we're talking about VHA. VHA has, depending on how you count, what you count as a hospital, 153 hospitals, 956 clinics, 134 CLCs, which are basically long-term care nursing homes. And then we also have vet centers, which are community-based readjustment centers, outpatient sites, and 90 residential rehab treatment programs. There are currently 6 million active patients at the VA, although there are 9 million, give or take, enrolled, but a good number of those are not active at any particular time. So 6 million patients, give or take, active at any particular time, 350,000 staff, give or take, across the medical center. Nursing alone, we have 93,000 nurses. So it's pretty crazy. Next slide. VA is divided into 18 regional networks, which are called Veterans Integrated Service Networks, or VISNs. And the reason this is important is, as I'll tell you in a second, this is how financing gets distributed from Congress, basically through VA central office and out to the field. And ultimately, that's how and why what we have to work with. Next slide. So a few more points, and then just a couple more background points, and then let me talk about the whole health approach, which is what it is that we are doing through my office and now really across the system. So the VHA budget this fiscal year is about $90 billion. And that money is mostly medical care services, although there are infrastructure and other IT and some other costs in there. The way most of the money gets distributed is through something called the VERA system, Veterans Equitable Resource Allocation. And so bottom line, what happens is that 90 billion gets divided between the 18 VISNs. I'm going to get to where I can say a whole sentence that's all acronyms, and then you guys will be honorary VA staff and fully qualified. But anyway, the VERA distributes the money across the VISNs, and then within each VISN, there's anywhere from 6 to 10 medical centers, and then a lot of outpatient sites. And the money is distributed to VISNs based on their case mix of veterans. How many veterans, what level of complexity, basically. So it's a fully capitated system at that level. It used to be then that the VISNs and the VISN leadership had a lot of jurisdiction or leeway in terms of how they distributed that money down to the medical centers. It's actually still that way. So the VISN leadership, the network directors do really have quite a lot of control over the way the funds flow. But there's now something called the MCAS, the Medical Center Allocation System, which basically divides the VERA money down into medical center level to some degree based on workload at the medical center. So how many primary care visits, how many whole health visits, et cetera, et cetera. So, we are, oh boy, 5 minutes. Okay, I'll skip over. That's enough background. So we're a capitated system, but it's not that simple. The other thing that makes it even less simple is that, as people know, there's a push and pull between VA dollars being used for care within the system and out in the community. So give or take right now, about 35% of VA dollars are going out to pay for care in the community under a third-party administrator, mostly Optum United. So whole health is this, basically everything you guys have been talking about so far. It's this idea that healthcare is not transactional, that the job of the healthcare system in this country has to be rethought, that it has to be thinking about the whole person from the get, that we have to figure out how to teach those poor doctors and nurses who thought they went into this to treat people, but then were told that they had to only treat diseases and not people. How do we get them back to where they are working with people again? And that's our big challenge. So we have this thing in the VA called the whole health system, which incorporates standard clinical care, but also adds in a number of complementary integrative health approaches, acupuncture, tai chi, yoga, et cetera. And more importantly, also integrates things like health coaching and whole health partners who are veteran peers, non-clinical people who are supposed to and do work with veterans to help change the conversation about what is the healthcare system doing for them, to help start to talk about what's most important to you in your life. What do you need your health for? Let us in the healthcare system get a grip on that so that we can start to orient your care and all our work with you around that. So really a new paradigm for what we're supposed to do. It's about delivering care and the transactions and the visits, but it's so much more. That's only a small component of what we're after now. And obviously the challenges in terms of payment, we have so many advantages in VA because of being an integrated system. And because if we can convince the system leadership to do something, it doesn't have to make money ultimately for shareholders, which is really a big plus. It does obviously have to deliver quality for the taxpayers. But the bottom line is we are still not a totally value-based system because VERA reimbursement is based on the level of complexity of the patient and in some measures, the number of visits that a given patient has. So for example, we have a category in VERA for whole health visits, and it requires that a veteran have 10 or more whole health visits in a year to get up into the payment level for that category. So there's still this funny mix of doing more in there as opposed to totally looking at outcomes. And I think most exciting for me about some of the things you guys were talking about is that we have to shift our point of view on outcomes. So in the VA, what we're working on is really looking at how does the system measure well-being outcomes. We're actually having a meeting in 2 weeks of well-being scientists from around the country, really, who are talking about what are the tools out there for measuring well-being and whole person health that are potentially applicable to being used in clinical settings. And so we're trying to push the system, that old thing, you get what you measure. So we're trying to push the system to more routinely measure what is whole person health and having some good traction, some real traction, and included in that, trying to get the system to become more activist, which it is already, but become more activist in screening for and addressing some of the structural determinants. So we're making progress, but we haven't gotten to where when a facility can deliver higher well-being scores on 40% of its patients, their Vera dollar reimbursement will go up. We are not there yet, but we're going to get there. We're hopeful. So in VA, we've got these challenges, but we have kind of all the tools that it takes. We just have to figure out how to get them together. In the private sector, I worked for 20 years at Beth Israel, New York, built an integrative health center, which is a wonderful place. We saw thousands of patients, 60,000 people a year. Very enlightened and exciting and whole person kind of orientation, but we never really made much money. Some years we broke even, some years we lost money, and we relied on philanthropy. Mount Sinai, God bless the health system, came in and bought Beth Israel along with half the other hospitals in New York. And I'm still a Sinai professor. My daughter goes to Sinai Medical School, so I love Mount Sinai. But they looked at us for income generation and not for value. And within 3 years of them taking over, we were closed or disseminated, you might say. So, private sector, fee for service, lack of total attention to value, I completely agree. That is done. That is over. It's never going to work. Let's just go on to the next thing. Okay, I'm done, I think. Thank you.
Thank you, Ben. As frank as you need a clinician to be.